Hello and welcome to this evening's Health Education England webinar designed for doctors returning to work during the pandemic. I'm Dr. Kirsty Smith, and I will be chairing this evening's session. It is a pleasure to welcome our speaker, Dr. Charlotte Frise, who will be covering tonight an approach to pregnant women with respiratory symptoms. Dr. Frise is one of the few obstetric physicians in the UK. She is a consultant physician in general medicine and obstetric medicine at the John Radcliffe Hospital in Oxford, and also works at the Queen Charlotte and Chelsea Hospital in London. She's also an honorary senior clinical lecturer at the University of Oxford. Thank you for joining us this evening. I'll now pass you over to Dr. Frise.
Great, thanks very much. I feel sorry for you because you should be having your evening meals and doing other things, but instead you've got me talking about a subject about which I'm passionate for an entire hour of your evening. You'll be unsurprised to know that I've tried to cram in as much as I possibly can that might be useful to you, both returning doctors to obstetric settings, both returning doctors to medical settings, but also I'm aware that quite a few people are joining us who are medical doctors who may not have done a medical take for a while and certainly may not have seen a pregnant woman on an unselected medical take. So the way I'm going to do it is to talk about the medical approach to a patient, working through history, examination, and then features that are specific to pregnancy of those tests that we do on the front door. I'm then going to talk very briefly about differential diagnoses, which will obviously include COVID, but this is not a talk solely about COVID. This is designed to be more useful, but to also help you remember other diagnoses that otherwise will be mislabeled as COVID in the next few months. It would be uncharacteristic of me not to put in some practical considerations that are useful for doctors on the front door about various things to do with pregnancy, and for the medics among you rather than obstetricians, it's designed to mean that you can have a conversation that perhaps doesn't make you it makes you look like you know what you're talking about when communicating to the obstetric team. If I have time and I'm allowed to, then I've got some cases, none of which will be COVID, but designed to show you that unusual things still occur in pregnancy and you should always be thinking about alternatives. So if we start about the history, if you're an obstetric trainee, you close your ears because you'll know this already. But for any medical trainees out there, we want a decent number of obstetric details. So from the point of view of previous pregnancies, we want to know when they were, whether there were any complications, and how your patient delivered, and whether there are any postpartum complications. So listen to her story and record those details because they're all useful. With respect to the current pregnancy, you need to know how pregnant they are, and that sounds a very basic consideration, but actually some women book late, some women only realise they're pregnant rather late. So not only find out how many weeks they are, but find out whether they have had appropriate scans and whether the scans agree with their dates, to get as much factual information as possible rather than just presuming that they are correct and that they're pregnant and that they are correct in the number of weeks. All of this is really important to your approach because your approach will differ according to trimester. We'll talk more about risk factors for VTE later on, but certainly be thinking about them in any pregnant patient just as you would a medical admission. This is the only time I'm going to mention risk stratification scores, and essentially just to remind you that there are no risk assessment scores that you would use for the acute assessment for VTE or for the risk stratification of people with PE in pregnancy. So put them to one side and don't even be tempted to use a modified version of them because they are not applicable for pregnancy. And when you're taking your history and thinking about cardiovascular risk factors, please be careful not to dismiss somebody with chest pain or other concerns about myocardial ischemia by the absence of your traditional risk factors. Yes, they may not have a strong family history and have a high cholesterol and smoking, but actually they can still have ischemic heart disease in pregnancy. With respect to examination, there are some things we know don't change in pregnancy. They are the temperature, the respiratory rate and oxygen saturation generally are unchanged, and peak flow. So view them, there's no clever modification you have to do. View them as essentially, treat them as normal. The issue comes when you talk about blood pressure and pulse. Blood pressure generally at the beginning of pregnancy dips quite early, and so a booking blood pressure, so a woman books her pregnancy around 8 to 12 weeks, will be a little bit lower than her non-pregnant baseline. There was previously thought to be a sort of mid-pregnancy dip in blood pressure, but actually that's not what we really see, and that has been backed up by a recent meta-analysis coordinated by people in Oxford, and said actually it doesn't really dip in the pregnancy itself. It will be slightly lower at the start and it goes towards the previous base, the non-pregnant baseline towards the end. The thing about blood pressure is that it might be a little bit lower. It won't be really, really low, so you won't necessarily be worrying about fluid resuscitation sort of levels, but just be cautious that it's a bit lower. The worry that I see on medicine, and the things I see done wrong is that people don't recognise a blood pressure that is elevated that doesn't trigger on a medical observation chart, but would absolutely be triggering on an obstetric early warning score chart, because the diagnosis of hypertension in pregnancy is a blood pressure over 140 over 90, and the threshold for diagnosis of severe hypertension is 160 over 110. This is not something we should be missing. Yes, it might be explainable by whatever else is going on medically, but it's one of those things that's quite easy to miss when your warning scores, early warning score systems are not designed for maternity, or maternity specific ones are not used. With respect to pulse, again, that's quite interesting. So your pulse does go up a bit in pregnancy compared to non-pregnant, and gradually increases through pregnancy. But the thing that has changed recently from publications from this group in Oxford is the upper limit of normal. And previously I was taught that a pulse of up to about 105 was normal in pregnancy, and a little bit greater if they were obese. Actually, more recent work done by the same group, but not this particular study, showed that a good number of women had a pulse that was otherwise deemed to be normal and they were well, up to about 115. So it's difficult to know what to do with these women, because obviously we worry about a sinus tachycardia. I wouldn't want people to be dismissing a sinus tachycardia in pregnancy. You still need to look for other things, but certainly the normal ranges, there's some recent interesting research about the revised normal ranges. When you are examining your patient, it's important to know that many women in pregnancy have a systolic murmur, and that will be a flow murmur, and but do look for other features. So look for radiation, look for other heart sounds, other signs of cardiovascular disease, and interpret in the context of an ECG. But in many women you'll hear a murmur, but it won't be concerning. The other thing that is commonly reported that would be normal is a third heart sound, but also ectopy. So ectopy occurs in non-pregnant and pregnant individuals, but for various reasons, it's either more prominent and occurs a bit more frequently, or is just a bit more obvious because of the increased cardiac output during pregnancy. With respect to bloods, I've put this slide up because the thing about pregnant women, particularly in other settings, is that their bloods can be normal for pregnancy, but either flag as abnormal because non-pregnant reference ranges are used in the lab for their automated reporting systems, or they are abnormal and they don't flag. And so an example of the first would be anemia. So we define, the World Health Organization defines anemia in pregnancy as less than 105 grams per litre in the second and third trimester. But there will be hemoglobin levels of higher than that flagging because of the different, the higher values used as the lower limit of normal in non-pregnant individuals. An example of the opposite problem is renal function. So in pregnancy, your GFR goes up and your urea and creatinine go down. So what would cause concern in non-pregnant individuals, perhaps a urea of 0.5 with a creatinine of 40, that would make people think of malnutrition and other causes, actually may well be normal in pregnancy. The problem is that if that increases to a creatinine of 70 or 80, that may not flag on your automated system, but it is abnormal for pregnancy. The other one where this is a problem to a lesser degree is liver function, and a similar pattern to a lesser degree occurs with your transaminases, and you see a mild decrease. So whilst an ALT of 45 may not be abnormal in a non-pregnant individual and it may not flag, actually in pregnancy that may well represent a mild increase and be worth taking note of. Other things that you'll do commonly include a CRP that is not changed by pregnancy. Troponin is not changed in normal pregnancy and normal delivery or normal cesarean section. However, there are myocardial changes that can occur in the setting of hypertensive conditions in pregnancy like preeclampsia, and so a troponin should be interpreted with caution in that setting. D-dimers, I could spend the next 10 minutes talking about D-dimers. Fortunately for you, I'm not going to. In short, there have been various studies in the last 18 months or so that come to slightly differing conclusions. But ultimately, we haven't dramatically changed our clinical practice as a result of these studies, and I do not currently use them or recommend them for the use of diagnosis of acute VTE. Blood gas, essentially, you get a mild respiratory alkalosis, but otherwise interpreted as you would do normally. From the point of view of an ECG, I put this up. This is a normal ECG for pregnancy, but I use this as an example because this produced an automated report from the machine it was taken on in a primary care department saying that this was abnormal. And you'll see small Q waves and T wave inversion inferiorly. That is normal with increasing pregnancy. And you can see sinus tachycardia often as well as a bit of left axis deviation. So everyone should always be cautious about machine generated reports, but please seek advice from people who are used to looking at ECGs in pregnant women if you are not sure, before worrying about the pathology. So I'm going to spend a few more slides, I'll use the next few slides to talk about radiation. And this is not a very good image I took from the internet, but to demonstrate some important principles in the understanding of radiation, because my aim from the next few slides is that you can go tomorrow into work and be more confident in your counselling of pregnant women who potentially need imaging involving ionising radiation. And this is not a nuclear physicist version of this. This is my simplified version to get the principles across. So the key thing is that you'll see two different measurements units used. You will see a measurement of a sievert or millisievert, and that is the biological radiation risk of the exposure. So a chest x-ray, machine doing a chest x-ray will give out a certain amount of millisieverts when it does it. But you will also see grey or milligray or rad used. Milligray is the commonest because of the levels we're talking about. And if I use a CT as an example, so a CT PA gives out a certain amount of millisieverts when it is performed, and that is a fixed amount of radiation per scan. The biological dose differs according to which part of the body you're scanning. So you can see that the milligray dose to maternal breast tissue, for example, which we'll come back to in a minute, being thorax from a thoracic scan, will be different to the biological absorbed dose to the baby. Now, there are ways in which people use sieverts and grey interchangeably. For the purposes of this, we're going to treat everyone listening as if they're not a nuclear physicist, and you'll allow me to keep this basic. But those are the principles of the sieverts versus grey. To give you an idea of the amount of ionising radiation, this varies hugely according to where you live. And I'm not really sure why it's relevant. The global average background exposure in pregnancy is 2.3 millisieverts. That's a number that is mentioned when you look at this from a population level, but ultimately people don't dramatically change where they're going to live. So although that's a useful number, I'm not sure it's actually very practical or helpful. But interesting from geographical variation here. If we then talk about, well, what are the risks of this radiation in pregnancy? Now, I'm not expecting you to ever learn this table, but what the aim is to give you an idea of the levels of radiation in milligray, so looking at the right-hand column, as to what is associated with problems in pregnancy. And I want you to see that the lowest possible level thought to be related to anything in pregnancy, and this is very early, is 50 milligray. Other things are talking about a rate of 200 or more. And this is important because you then need to think about the milligray from the common radiological procedures we perform. And they are orders of magnitude different to the levels at which cause problems in pregnancy from a single exposure. So a chest x-ray is a good example, so it's 0.01 milligray. And generally the common ones we do are all under 1 milligray. I'm just putting in an abdo x-ray there and a CT pelvis just to show you that obviously as you are increasing the amount of millisieverts from the procedure you're performing, so CT compared to an x-ray, the biological absorbed dose to the fetus will go up, but as will the nature of the scan. So if you're scanning the pelvis, the dose to the pelvis will be greater, so that's obviously higher to the fetus than a CTPA. In short, you should never worry about performing a chest x-ray in a pregnant woman. If you would do it in a non-pregnant individual presenting with the symptoms that that pregnant woman is, you should just be doing one. And you can't even tell you how many Brazil nuts 140 grams is, but it's not very much. And we need to be really reassuring. Part of the reason for this is that you may see a number of pregnant, I may see a pregnant woman and request a chest x-ray, you know, every week or two. But for the radiographer performing that chest x-ray, they may be the only pregnant woman that that radiographer sees that year. And therefore, there is understandable anxiety from the people performing the test. And that has led from previous experience to people worrying. So you send them over for a chest x-ray and there's worry, or it's not done, or there's questions, or they're made to doubt their decision. So it's really important that you are happy with discussing this radiation dose being very small and being able to instill confidence in the person that's about to have it. And the chest x-ray shouldn't be delayed because of any concerns with pregnancy, from doing it in pregnancy, I mean. So if we talk a bit more about a VQ scan, and I think this is important because, as we will touch on with COVID a bit later, the features of COVID are going to overlap in some with the features of PE. And sinus tachycardia, breathlessness, all of those things. And we know pregnant women are more at risk of PE, and we know that some of these women are going to have scans of PE. So we need to decide what we're going to do. Well, in COVID, it's going to be slightly academic. I suspect we're not going to be doing very many ventilation perfusion scans because of the likely ventilation abnormalities as a result of probable COVID. But just to fill you in and give you the background so you know all of it, different hospitals do ventilation perfusion scans different ways. So Oxford essentially use a normal chest x-ray as a surrogate for normal ventilation, and so that avoids the part of the test that involves inhalation of the radioisotope altogether. It is also possible to use do a half dose Q scan, so use half the dose of the radioisotope for the perfusion part, and that is not felt to be inferior to a full dose scan. So you can reduce that radiation significantly by omitting that it's low to begin with, but you can reduce it further by assuming the ventilation is normal if the chest x-ray is normal, and use half a dose of that Q scan. The interesting thing comes about performing it after delivery, and I hadn't really appreciated this until I had worked in obstetric medicine for a little while. Now, it seems very straightforward to tell a breastfeeding woman that their guidelines say they need to express and discard their breast milk for 12 hours after the scan. However, for a woman who's potentially newly delivered, that is a really potentially difficult thing to do, particularly at the window you want to do it. This is not a woman who's got 3 days to go to the supermarket, buy this, bottles, buy formula milk to feed her baby, and buy the kit that she needs to pump that breast milk. This is done because she's in hospital requiring investigation for a PE, and it's usually required a decent speed. So whilst it is in the guidelines and it is driven by the likelihood that a low level of radioisotope is in the breast milk, actually this is a really hard thing to do. So if you're going to ask this and for them to do it and mention it as a possibility, please involve your midwifery colleagues early, or ensure that they have got some form of support if they have not done this before. And please don't underestimate the task that you're asking them to do. It gets even more complicated when you talk about doing this in the first few days after delivery, because there was guidance produced at the beginning of last year that said actually we don't know about the radiation levels that are in colostrum, and therefore the breastfeeding mothers should be suggested that feeding should be interrupted until the samples have been sent to a lab to look at the radiation dose and prove that this is safe, at a safe level for them to recommence breastfeeding. Whilst that may be reflective of the lack of evidence about it, that isn't really very feasible practically. So I think that whilst noting it, this shouldn't necessarily alter what you do. From a CT perspective, and this applies to CTPA, we'll talk about that in a minute, but certainly with respect to CT in pregnancy, the radiation dose to the fetus is low. So if you looked at the radiation dose to the fetus alone, one could argue that a CT was attractive. However, please remember that these are both really low doses. But please also remember, these exact doses will vary according to the scanner that is used locally to you and the exact procedure of scanning that is used. So take these numbers as a ballpark, but they're not absolute and immediately transferable to everyone's local department. Now, over the last few years, there's been significant concern about the radiation dose to the mother, and it was felt that various studies suggested that a CT in pregnancy, while a woman was breastfeeding, was a radiation dose to breast tissue, which was even more susceptible than normal because of the physiological changes in pregnancy and lactation. It was even more vulnerable than normal to radiation damage, and there was a suggestion of an association with breast cancer. However, I steer you towards the most recent European Society of Cardiology guidelines for the diagnosis of acute PE, where they say actually modern CTPA imaging techniques expose the maternal breast to much lower doses than we were previously quoted and considered. So we were quoted sort of 10 to 60 milligray per breast. And actually the important bit is next, which says the effect on maternal cancer risk is negligible, and therefore avoiding CTPA on the grounds of that maternal cancer risk is not justified. And this is important because this will if there is a woman who has a potential PE in the differential diagnosis, then you're unlikely, if it's in the next few months with COVID, to be doing a VQ for reasons I've said anyway, but also even if it's not related to COVID, there is not a good reason for delaying them for, say, 3 days over a weekend when you can't get that nuclear medicine scan to wait. And so avoiding CTPA on the grounds of cancer risk is not justified, so we potentially should be doing them a bit sooner. The problem is that you will encounter that really difficult CTPA report a bit more frequently in pregnancy than in the non-pregnant individual. And that report is the one that says suboptimal opacification of the pulmonary trunk. So there are no big PEs, but small ones can't be excluded. And that's really tough because then you have to think about whether you need to perform a second different imaging modality. And the reason that occurs more commonly in pregnancy is because the timing of the administration of the contrast intravenously in the antecubital fossa is calculated on the basis of a non-pregnant cardiac output. And in pregnancy, your cardiac output increases by 40 or so %, and you can see why that would therefore change the timing of image acquisition and potentially risk causing problems. So this is just to put in a kind of summary. I'm sorry, the red bits don't appear to come out very well here, but it's just to mention that we've talked about an awful lot about pregnancy considerations and those women on the medical take. And I have summarised it in this document here, and because various people wanted to use it in their own unit, I've stuck it on a page on my website so anyone can download it. I'm now going to take you through a few other practical things to consider when you're seeing a pregnant woman on the medical take. And we're going to skip through these quite quickly, but I just want to point in the direction of some resources. So be careful what you say about medications in pregnancy. Don't underestimate the impact of suggesting that someone's medication is potentially toxic to their baby. If you are not sure, you are allowed to be honest with the patient and seek help and advice before making significant decisions, because it's very hard to undo it when somebody has confidently told a pregnant woman that the medication is unsafe. You will have a local high-risk obstetric team, so it may not have an obstetric physician in it, but there will be obstetricians in every hospital that look after the more complex pregnant women, so it's a case of finding out who those people are. And the website called BUMPS, which is the best use of medicines in pregnancy, which is coordinated by the UK Teratology Information Service, has loads of patient information leaflets that are helpful to you. A lot of it will be summarising that there is a lack of definitive evidence, but it can be very useful when counselling your patients. And we're now going to touch on a few medications in a bit more detail. So, in general, we have a whole load of antibiotics that can be used appropriately in pregnancy. In general, penicillins and cephalosporins are fine. And please think about using clindamycin when you see a septic pregnant woman. Remember that pregnant women are more at risk of group A strep. You will see a different empirical antibiotic combination in your local trust guidelines, so there is much more likely that clindamycin is there, and please remember that different guidelines exist and make sure you look for them if somebody is septic. We use erythromycin in pregnancy commonly, clarithromycin less so, but it can be used. There's recently been a suspicion about macrolides, particularly in the first trimester, so if you have alternatives, they are attractive, but I wouldn't say that there are particular problems being identified yet. And gentamicin is interesting. So gentamicin, people worry about a lot because there were concerns about ototoxicity with the use of streptomycin. However, these haven't been proven in small series where doses of gentamicin have been given. And the reason I mention this particularly is that we are often only using gentamicin when a woman is septic. And please remember that sepsis is life-threatening to both mother and baby. And gentamicin is a really good antibiotic. So if you would use it because somebody is floridly septic and needs it, then there is not a pregnancy reason why you cannot give them a single dose of gentamicin. The ones we tend to avoid are tetracyclines because of issues about teeth, and fluoroquinolones because of the potential effects on fetal bone and cartilage. So please just remember that when thinking about particularly alternatives in penicillin allergic women. Anticoagulation. Well, low molecular weight heparin is fine. It doesn't cross the placenta, but please remember that bigger doses are required, and you will need to look at your local maternity VTE guidelines or power plans if it's in your electronic record. We occasionally use warfarin in pregnancy for our highest risk women, and those are essentially the ones with metal heart valves who are not in the first trimester. There is a risk of embryo toxicity in the first trimester, and there is a risk of fetal hemorrhage later on in any trimester, because in second and third trimester, because the fetus has lower amounts of vitamin K. So therefore, if the mother has an INR of 2 or 3, the baby is going to have a higher INR. Warfarin can be used in breastfeeding, but we don't tend to switch people over until at least a week after delivery. You will all be much happier as medics with DOACs, but we have no good evidence and a suggestion of harm in pregnant animal models, so we simply don't use them, don't advocate their use in pregnancy or the postpartum period at the moment. Now, this isn't designed for you to go away and remember all of these things. It's just to point out. So this is an example of a risk assessment tool for VTE in pregnancy. And it's just a reminder that risk factors in pregnancy differ. It's pretty straightforward if they are an inpatient with you. If they don't have acute bleeding concerns, then as any medical inpatient would do, you would be giving them you would be giving them pharmacological prophylaxis. The same applies in pregnancy, but again, there'll probably be a different power plan, there'll be different risk factors and different forms to fill in, so just be aware because they may not be quite as obvious to you. And just to mention about steroids, because I think there's quite an important message here when people are thinking about pregnancy with any respiratory conditions. There are two types of steroids, and you can divide them by their chemical structure as to whether they are fluorinated or unfluorinated. And fluorinated ones include dexamethasone and betamethasone, and these are really useful for obstetric indications. So these are, betamethasone is commonly used to enhance lung maturation for the baby if there is a likelihood that this baby is going to be born preterm. And you may also occasionally see dexamethasone used for the management of congenital heart block, but that's a whole different talk. However, non-fluorinated steroids such as prednisolone, methylprednisolone are metabolized by the placenta, so the fetal dose is much smaller. So you will see us using prednisolone much more as we normally would if they weren't pregnant, but we'd use it for treatment of maternal medical conditions, and we would use the same doses as we would if they were not pregnant. You can be therefore very reassuring to your patient that the fetal dose is small. In short, lots of things have been suggested associated with doses of steroids in the past, but there isn't a clear association with either exposure in the first trimester or growth restriction later on. I think it's always very difficult with medications to tease out any fetal consequences like growth restriction from between the medication and the indication for that medication. The main things we have issues with the steroids in pregnancy is the hyperglycemia being the predominant side effect for the mothers. The same treatment principle applies, but essentially you will find yourself using steroids as you would do in a non-pregnant individual, because the fetal risks of not treating that inflammatory maternal condition properly are going to be greater than the theoretical risks of using that steroid as treatment. This is just a quick reminder about medication that is okay. You should be avoiding those stronger ones like cyclophosphamide and valproate, but you may see the occasional patient receiving these medications. And these are the ones that I never prescribe, really. But you need to, if you're seeing them in any other setting, if you're seeing a woman of childbearing age and any of these medications, that should be triggering anybody who sees that person to have a thought about contraception. So moving on to the differential diagnosis of respiratory symptoms in pregnancy. We're going to touch on a few of these. I'm not going to talk more about anemia or asthma in this, but the treatment principles we've covered already. So, well, what happens in pregnancy? Well, quite soon after conception, surprisingly early, the hormonal effects lead to a change in the respiratory pattern, so an increase in minute ventilation and an increase in tidal volume. As the woman becomes more pregnant, you then get more of a physical effect of the pregnancy restricting their respiratory function, and that is a simply practical one because of diaphragmatic splinting. It is really common to be breathless simply because people are pregnant. This is not a pathological finding, and the classic thing is that they've noticed it a bit more often from the first trimester. It's not usually sudden in onset, but it is most commonly noticed on exertion, but often on talking on the phone. Often people find that they need to interrupt their sentences to take a breath in a way that they wouldn't when they are not pregnant. It is really common, so probably over 70% of women at about 32 weeks will have noticed it as a symptom, but not worried about it necessarily. So it wouldn't be any talk in this day and age without talking about COVID in pregnancy. And this is a slide I put together for people who hadn't necessarily seen COVID in practice much yet. And I just wanted to draw out a few things about COVID in pregnancy. The real problem is that we are inevitably going to encounter in the next few months is that the features of COVID and the huge prevalence of it are going to affect people's diagnostic approach to these women. And so there are going to be women who have pregnancy related complications, as they normally would, who are mislabeled as COVID. And so therefore it is important to always remember, first of all, the other diagnoses, but also to remember and reflect on the nature and the effect of a pandemic and a diagnosis that is so common on the human factors and the behaviour and diagnostic approach when you are seeing these women. Again, reminder of the respiratory rate and the oxygen saturations. So we use respiratory rate as a very subtle marker, as an early marker in pregnancy of respiratory compromise, but actually it's been increasingly noted that in COVID the hypoxia is often out of proportion. So it's a reminder, and this is straightforward on a medical setting, but perhaps isn't routinely done in obstetric, to make sure that those oxygen saturations are done even if the patient looks otherwise normal. Women who are pregnant, even without preeclampsia, are more at risk of fluid overload, but it's a reminder that this doesn't behave like bacterial sepsis, so we need to be thinking about other causes of their presentation, but again being very hesitant with our being very careful with our intravenous fluid use. The problem with the blood tests is that there are obviously other things that can cause similar presentations, and you can imagine that seeing mildly deranged liver function may well be a setting COVID, but it's also a feature of preeclampsia. So we have to be interpreting these results in looking at the whole clinical picture of the patient in order to make sure we get the diagnosis right. We've talked about antibiotics already, and pregnant women are generally not going to be on ACE inhibitors, so it's going to be less of an issue. But ACE inhibitors, enalapril and captopril, are used for the treatment of postpartum hypertension, and although it has not been proved and there have been no professional body guidance supporting ACE inhibitor cessation, actually if you have a reasonable alternative to the use of an ACE inhibitor, then a useful alternative is attractive for those women starting it afresh after delivery. The Royal College of Obstetricians and Gynecologists have been great at producing guidance. They're on their 5th version of their COVID infection and pregnancy guideline that was published on Saturday. And for people more involved in obstetrics and maternal medicine, the 1st version of a very useful guide for maternal medicine and the common conditions we see, such as diabetes and hypertension, were published yesterday. So I steer you towards those for a bit more information. In short, this is not like swine flu. So swine flu and seasonal flu, there's something about it that is, and the immune changes in pregnancy that mean pregnant women can get really sick with it. COVID does not appear to be behaving in that same way, but obviously we are still going to get sick pregnant women at the same rate we would do in other non-pregnant patient groups of the same age. Breastfeeding, so the initial data from China advocated separation of the mother and baby for 14 days to avoid transmission to the baby, but the guide that isn't clear that was the right thing to do. It would have been protective, I'm sure, But the RCOG have taken a sensible line saying actually we shouldn't underestimate the psychological morbidity of doing that to a newly delivered woman, and we have to be sure of the risk to the baby. So actually in most cases it will be absolutely fine to keep the baby with the mother, and if they're on a medical ward because of their respiratory function, again we need to facilitate that, and with careful infectious precautions, but not separate. We do not need to advocate separation. So I'm just going to touch on PE. We've touched on it almost in every sort of theme so far. We've talked about it with respect to not doing D-dimer. We've talked about CTPA and VQ scans. The problem with PE in pregnancy is that despite everything and our risk stratification and our administration of DVT prophylaxis in pregnant women, it is still up there as a cause of maternal death. And this is the most recent chart about causes of death in pregnant women, produced by the wonderful resource which is the Embrace UK report. This is the kind of modern version of what was started in the 1950s as the Confidential Inquiry into Maternal Deaths, and it is a unique resource in the UK, and looked at every woman who died in pregnancy and the postpartum period, and has looked at patterns since the 1950s, has looked at all sorts of things, and it's really an amazing resource. But thrombosis and thromboembolism is still up there despite our best efforts. So it is right to be thinking about it as a differential diagnosis, and it is right to have a low threshold for imaging these women. Couple that with the fact that now the national guidance is that pregnant women are essentially self-isolating for most of their pregnancy. So you're taking what otherwise pretty mobile pregnant women, you know, working or running around after small children, and by definition they are going to be less mobile than they would otherwise be as a result of that self-isolation. So we immobility is an official risk factor, but again the definition of that is difficult. Is that absolute immobility because they've had an injury and they're bedbound, or is it relative immobility? And I think that's a really difficult one, and I think it's something that we need to be having a look at as time progresses through this COVID pandemic. The other thing that has been noticed anecdotally, rather than, and that comes with an enormous caveat obviously, is that when you're doing a CTPA to look for PEs, you're giving intravenous contrast, and in people sick from COVID already, where there is a significant incidence of an acute kidney injury, you may be making that renal insult worse by giving IV contrast as well. So just remember that CTPA is not a benign intervention. So although we're reassuring about radiation, this isn't something we should just be advocating in every pregnant woman just in case. There is an alternative to deciding on the front door whether they immediately need an imaging for PE or not, and that potentially is giving them a pregnancy specific treatment dose of heparin, so treating them as if they have a PE, if that's really in your differential diagnosis and you're not sure, but that will cover you prior to further imaging to get more results back, to get that COVID swab back, and to make a decision about whether they really need imaging for a coexistent pulmonary embolus as well. Pulmonary edema, I have only 2 slides on pulmonary edema. The key thing to remember is that it isn't always a cardiac cause. So non-cardiogenic causes, I guess, of pulmonary edema are more common in pregnancy. So if you think the patient clinically has pulmonary edema, then it isn't, so the presence of a normal looking ventricle and ventricular functional echo does not exclude that as the clinical situation. It doesn't mean that you are wrong. It just means you have to think about alternative diagnoses. Hang on one second. Moving swiftly on. So just remember your clinical assessment, and if you are thinking that the patient looks like they're in pulmonary edema, then you're probably right. And remember that as a differential diagnosis when you're seeing pregnant women breathless presenting and being sent through that respiratory emergency department as possible COVID. Peripartum cardiomyopathy is an entity that worries people who don't see many pregnant women, and the key things are that the presence of pulmonary edema is most often due to something else, and that does not equate to the diagnosis of heart failure, as I've said. But the other thing is that even if you see an impaired ejection fraction on echo of a pregnant woman, that still doesn't equate to them having peripartum cardiomyopathy, and they may well have other causes for that impaired ventricular function. And it's just to say that actually the PPCM is easily overdiagnosed because of the lack of consideration of other diagnoses, but it's a really important diagnosis to make and be clear of, because it impacts advice about future pregnancy in a different way to that associated with other causes of impaired ejection fraction. So I now have a few slides to just talk about practicalities and when you need to phone an obstetrician and what you're going to ask for. So top left is a sonic aid, so a fetal heart auscultation, and that is normally done from about 16 weeks of pregnancy. So if they are early in pregnancy, you're simply not going to be able to hear a fetal heart by listening abdominally, and so 16 weeks onwards is what you need. The ultrasound machine, an ultrasound can be performed at any gestation, but if they are very early, they may only be able to, it may not be that an abdominal ultrasound is what you need, and they may need a transvaginal scan. But certainly that will give you a lot of accurate information if it's required. But not every pregnant woman admitted needs an immediate ultrasound, but they do need a thought about fetal assessment. Pictured at the bottom is a CTG machine, or cardiotocography, and this measures two things, and the top line is the fetal heart rate and the bottom line represents uterine activity, and that is all I as a physician am going to say on the interpretation of CTG, but this is most useful from about 28 weeks of gestation. So don't phone up and ask for one on a patient who's 18 weeks, because not only is it not the right thing to do, when they are earlier than 24 weeks, actually the decision making is different. So for example, if somebody was 30 weeks and ill and they had a very abnormal CTG, that would potentially be an indicator for immediate delivery. However, if they're 18 weeks and there is worry about the baby, actually there is slightly less urgency potentially, because you can't deliver the baby in order to save its life because it is not viable yet. Location is a really common and difficult question, and I put these up just to show that actually none of those places is an ideal destination for every pregnant woman you are asked about, and you will need to make an individual decision based on the clinical priorities for the woman in front of you. So please don't simply say no, because they're pregnant they need to be on obstetrics, or because they're early they need to be on gynecology. We really have to be sensible about the decisions we make about these, where these women are best looked after, and the best thing to do is not just say no, but to talk to the people involved in the care and have a sensible discussion. There is often not a perfect place for this patient to be looked after, and so a sensible plan has to be created and involving potentially a number of teams. Talking about delivery, in short, leave the delivery decisions to the obstetricians. So whilst a medical input is really, really important with respect to consideration, so type of delivery, the onset of delivery and how we're going to do it, ultimately the responsibility for that delivery decision rests with the obstetrician. So you don't have to be able to give that patient clear guidance, and the solution is often not simply to do a cesarean section. I mentioned breastfeeding before, just briefly, about keeping women together. Often in non-obstetric wards in hospitals, there are issues about looking after the baby, and it's absolutely right that the nurses are not responsible for both in the care of the baby and the mother. However, please prioritise keeping that baby and mother together if you can. If there is a mother there a few days after delivery, make sure you ask about her baby and think about those practical implications of the mother and baby being separated for any length of time. If there is an alternative caregiver who can take responsibility for the baby, then often that recently delivered mother can be present on a medical ward with a relation or the father of the baby taking care and responsibility of the baby. And that is particularly relevant for breastfeeding and maintaining their supply. And it shouldn't be assumed that needing medication for a short time that is not felt to be appropriate in breastfeeding should lead to them stopping breastfeeding altogether. So please, if you're not sure, ask about what advice to give. Seek out your infant feeding team, seek out the midwives. They will come and help you and be able to support that woman, and you will make a massive difference to her if these things are thought about. I think I have the last 10 minutes to tell you about a couple of cases. The diagnosis is not COVID. The diagnoses are interesting, but just to make you think and to always keep that medical hat on when you are assessing these women. So this was a 22-year-old woman who had had one previous completely normal pregnancy and had a bit of mild asthma. She had been completely well until 32 weeks, but had stopped sleeping properly and just felt less well for about a week. Her GP saw her because she had noticed she was breathless, and she was given prednisolone and antibiotics for a presumed exacerbation of her underlying asthma. But on the day of admission to hospital, she got very breathless and an ambulance was called. And she also reported a number of other symptoms, including chest pain, cough and abdominal pain. She had had, and she had been vomiting for just over 24 hours. On admission, she was clearly unwell. She clearly worried the admitting doctors, and a number of senior doctors needed to see her early. So she was described as struggling to breathe. She was very dry. She was tachycardic. She had a blood pressure. So looking at those numbers, 110, well, yes, I've just told you that that might be normal, but in this setting it's probably not. Looking at her blood pressure, 145/70, so it's not sky high, but I certainly take notice of that because that does count as hypertension, and I would want to make sure that that was repeated and looked at and addressed and not just dismissed. And she was clearly extremely tachypneic with normal saturations. Just a note on urine dipstick. When we look at protein, the best test for assessment of urine protein is either a 24-hour urine collection, but that is practically a bit of a pain, or a spot protein creatinine ratio. A dipstick is useful to some extent, but I wouldn't view it as diagnostic. And the key thing is that 1+ of protein represents a significant PCR, so that's defined as over 30 in about probably 20–25% of women from our local study we did, if not less than that. 2+ of protein, more like 50% of people with 2+ of protein have significant proteinuria when clarified on PCR, and 3+ or more very likely to be significant. And she's also got 4+ of ketones. Ketones, again, not uncommon in low levels in pregnancy and often completely ignored on the dipstick. Her results. So I've highlighted the relevant ones for you. The white cell count goes up a bit in pregnancy, but I wouldn't explain a total white cells of 23 by pregnancy alone. Her creatinine looks relatively normal for a non-pregnant, but actually that is abnormal for pregnancy. Her urate is a non-specific marker but useful and may be associated with preeclampsia, and that is significantly elevated there. But much more concerningly, and not highlighted in red, is her arterial blood gas, which shows a partially compensated metabolic acidosis with a bicarb of 8 and a base excess of -22. She's clearly working very hard with her respiratory rate of 60 to compensate. And her capillary blood glucose is 4.2 and the capillary ketones are 4. So she's taken to theatres, she's given Hartmann, she's given saline, she's had an art line put in, and she's given fetal and intramuscular steroids because, to accelerate fetal lung maturation given her gestation. She doesn't get any better, and she has an emergency caesarean section at 9 o'clock at night. The baby is born in good condition, needs to go to special care, but she makes a complete metabolic recovery in the first 12 hours after delivery. So what was the diagnosis? Well, the astute of you probably all spotted the significant ketones and the significant capillary ketones of 4 here. And she had a condition called starvation ketoacidosis, so her breathlessness is actually likely to have been driven by ketosis. Pregnant women are more prone to it. She'd been vomiting for 24 hours, which is quite typical of the cases described. So please always think about other causes, and particularly given that blood gas. Have I got time for one more? Oh, I'm going to keep going. The next one is a 41-year-old woman who we met with vague symptoms in the 3rd trimester of her 3rd pregnancy. So she had noted a bit of shortness of breath, a bit of weight loss, a bit of abdominal pain. She had only realised she was pregnant at 23 weeks, so she had a scan just after that. And over the next few weeks came in and out of her local hospital with breathlessness, treated as a chest infection. She'd had a headache, but again admitted with breathlessness and didn't manage to have imaging. Did not tolerate it and was discharged at 28 weeks. Otherwise, she was on aspirin from the point of view of preeclampsia prophylaxis, and examination was pretty normal. The only abnormal finding documented when she was met at 30 weeks was that she was unable to speak in full sentences. Her blood tests were normal. Her ferritin was a bit low, but her haemoglobin doesn't count as anemia for that gestation. Her ECG and chest x-ray were reassuring, and a Q scan showed she didn't have a PE. So she was discharged, and a tertiary centre respiratory review was arranged for a few weeks' time. At that appointment, they took a history going back further than the pregnancy, and had found that she'd actually been breathless 9 months prior to this presentation, so way before she became pregnant. And at that time, she'd had quite extensive investigations, but most concerningly, there was a bit of atelectasis or bronchiectasis on the HRCT done, but much more concerningly, at the 6 months prior to this presentation, she'd had a severe restrictive pattern identified on lung function tests. When further symptoms were asked about, she said that she had absolutely been breathless when walking, but particularly upstairs or lying flat. She had found swallowing and chewing more difficult recently, so she had lost 20 kilos of weight over about a year. And she said it felt like her neck does not support my head properly, and that she's just generally felt weak and tired. So she had various tests that showed they not consistent with TB. They looked at a blood gas taken at 28 weeks, which showed a type 2 respiratory pattern with a CO2 of 7 and a bicam of 33. And again, the lung function with a similar severe restrictive defect with an FVC of 0.7. So they thought about putting her on an NIV. And in the style of a New England Journal article, a diagnostic test was sent at that point, and she was given empirical treatment for the likely diagnosis of myasthenia with pyridostigmine and IVIG. And that diagnostic test later came back to show that she was anti-MuSK antibody positive. She was delivered at 35 and a bit weeks and started steroids after delivery. She made a bit of a respiratory improvement with the treatment, but she was delivered because actually she didn't make an overwhelming recovery. I think for the purposes of time, we're going to flick through this one, and I'm going to finish on a slide that tells you about different resources in pregnancy. So I've mentioned the RCOG guidance for COVID already, but whenever you're thinking, and I've mentioned the BUMPS website as well, a really good app that you can all download tonight that is free, called produced in the US, is called LactMed, and it goes through each medication in great detail about the actual evidence and published evidence about use of medications in pregnancy, and it's a very helpful resource. If you are looking for the equivalent of BUMPS, but for breastfeeding and medications, then the Breastfeeding Network is really helpful too, and has lots of advice about different classes of medications. And then to all the medics out there who might not have come across the Embrace report before, it's a really good resource, and it's worth reading about, not to scare you, but simply to show you that women in pregnancy get sick because of medical conditions with which you are already familiar. They are not dying from conditions you've never heard of and you can't manage. They're dying of medical things that we all know how to manage, but we're less confident doing so in a pregnant or recently delivered woman. So I think I should stop there, but I'm happy to now look at the question feed and see if there's questions I haven't addressed.
Yes, thank you for that very informative session. I've taken away a lot of practical information for this group of patients who might be a little bit less familiar with. I've been having a look at the Q&A and we have a few questions on it. First of all, about the first case with starvation ketoacidosis, knowing the diagnosis, was there any other management that you would add in?
Yes, so a great question. I could talk all day about starvation ketoacidosis. So the key difference is that if a woman has diabetic ketoacidosis in pregnancy, we treat her medically with the anticipation that she will get better. And you would only ever deliver somebody with DKA whilst they were unwell if there were acute fetal concerns on your monitoring that looked like the fetus, needed delivery rather than anything else. The thing about starvation ketoacidosis is it's often not spotted, and the solution to it is treatment with dextrose plus or minus insulin. The reason I've said that in that order is because often these women have been vomiting and they are carbohydrate deplete, and therefore they are not producing they're not producing very much insulin. You can give them glucose, which is enough to allow them to increase their endogenous insulin production, and that insulin they produce will be enough to suppress ketosis. So I would absolutely, in the next case, would give her intravenous glucose containing fluids, because she only had Hartmann's and saline, with the anticipation that she would get better from it and didn't need an emergency delivery. And I would add in insulin if my glucose had made her hypoglycemic, but that doesn't often happen. The endogenous insulin is almost always enough.
Thank you, that's clear. So a few questions about CT scans as well. Does the radiation risk vary in the developing fetus in different trimesters?
So I think the key thing about it in any trimester is that the dose is very small. And so if you looked at that slide that I can go back to with the thresholds, actually it's way below the threshold that is thought to cause any problems in any trimester. So I don't think it differs because I don't think it's high in any of them.
Mm-hmm. For CTPAs, could the contrast administration timing be adjusted to take into account the higher cardiac output so that we have a better image?
So absolutely, good question, and something that I think people much cleverer than I have been thinking about, but for whatever reason that hasn't happened, despite the fact we know that this is a repercussion of pregnancy. So I suspect it's probably harder to do than I think it is from a sort of radiological perspective.
Yes, well, we really appreciate you sharing your expertise with us this evening, and thank you for attending.